Hi everyone, my name is Jenny Ahmed. I'm one of the EMIM interns. So I'll be presenting on my clinical pearl endocrine topic today. So thanks to Dr. Delgado, Dr. Tan, Dr. Madden, and Dr. Adrenal for their assistance in putting this together. So we'll start with the case. So your patient comes in to CCT. She's a 27-year-old female with no known past medical history, presented with altered mental status and vomiting for the past 1 day. Her vitals in triage are a blood pressure of 80/50, a heart rate of 120. She's afebrile, and she's starting well on room air. Her ABCs are intact, but no finger sticks available yet. So I guess what would you do given these vitals in the presentation of your patient initially?
I do some ABC, I do.
There you go. So great. So you decide to start some fluid resuscitation. Start with 2 liters of fluid and obtain some blood work. So your exam findings are really not very specific. Your patient is drowsy, oriented only to self. She has diffuse abdominal tenderness and guarding. And so you go ahead and repeat her vitals after the 2 liters of fluid and find that they've not improved. Her blood pressure is 70/50. Her heart rate's 115. She's still afebrile, still saturating well on room air, but you're getting a little bit concerned. In the meantime, you get a call from blood gas with a critical. So I call you on the phone and say, "Doctor, glucose is 35. What's your name?" But before they hang up, you ask quickly for a readout of the rest of the lab values and perk up at the mention of the sodium of 119 and a potassium of 6.5. For the sake of discussion, not hemolyzed. So you think you know what might be going on. So today I'd like to just talk briefly about the clinical presentation of adrenal crisis. Just review the pathophysiology of adrenal insufficiency and discuss the treatment pathway for acute adrenal crisis. So adrenal crisis results basically from 2 sort of main pathways of causes. It can result from the acute destruction of the hypothalamic pituitary adrenal axis or actual destruction of the adrenal glands themselves versus acute stressors in the setting of primary or secondary adrenal insufficiency. So common stressors include acute infection, particularly gastrointestinal infection, surgery, extreme physical activity, severe injury or burns, dehydration, and classically cessation of chronic glucocorticoid replacement in someone that needs it. So I just wanted to look at some classic causes of adrenal crisis, things that kind of show up on exams sometimes. So if anyone can tell me what cause of adrenal crisis does the picture in the middle represent? Yep, exactly. So this is adrenal hemorrhage and the setting of Neisseria gonorrhea infection, so Waterhouse-Friedrichsen syndrome. And so the other one on the bottom right, can anyone tell me what's represented here? It's classically seen in postpartum patients. Exactly. So this is Sheehan syndrome, where you have infarction of the pituitary gland, leading to a number of downstream effects, one of which can be adrenal crisis due to lack of ACTH from pituitary. So adrenal crisis classically presents as shock that's refractory to volume resuscitation and vasopressors. So we can briefly review the pathophysiology of adrenal insufficiency and how it kind of correlates to these clinical features of adrenal crisis. So patients with adrenal insufficiency typically will present with kind of chronic vague complaints. Classic lab abnormalities include hypoglycemia, hyponatremia, and hyperkalemia. The driving forces behind both the physical manifestations and lab abnormalities are inadequate amounts of aldosterone and cortisol, which are produced in the outer 2 layers of the adrenal cortex. So I'm sure you all remember mineralocorticoids, notably aldosterone is produced in the zona glomerulosa, and glucocorticoids, notably glucocorticoids, so cortisol, is produced in the zona fasciculata. So at its core, the presentation of adrenal crisis can basically be understood by the functions of cortisol and aldosterone and what happens when we don't have it or when we don't have enough of it to respond to a specific stressor. So I just want to take a minute and talk about how we see the effects of the depression of cortisol and aldosterone specifically. Okay, so starting with cortisol, one of the major functions of cortisol is systemic suppression of pro-inflammatory cytokines. So when we don't have enough cortisol, we're basically removing that inhibition, leading to an overall pro-inflammatory state. And then cortisol also has hemodynamic effects. It potentiates basically catecholamines, works kind of synergistically with them to cause vasoconstriction. So it kind of stands to reason that when we don't have cortisol or we don't have enough in adrenal crisis, no matter if we kind of keep giving catecholamine adjunct suppressors, we may not be solving the underlying problem. And so without cortisol, without steroids, we're not really getting that effect of clamping down. And so lastly, kind of the metabolic effects of cortisol shows some of our lab abnormalities that we'll see. So the metabolic role of cortisol is primarily catabolism, so breakdown for fuel. And so works on kind of multiple fronts, stimulating gluconeogenesis in the liver, production of fatty acids, and promoting release of amino acids. So clinically, one of the consequences we can sort of detect is hypoglycemia, which you saw in this patient here. And then just briefly about aldosterone, when the entire adrenal gland fails, aldosterone is also deficient. So the role of aldosterone acts primarily in renal collecting ducts to stimulate reabsorption of sodium and secretion of potassium and hydrogen ions. So when there's deficiency of aldosterone, this causes wasting of sodium and with retention of positively charged ions, potassium and hydrogen. And so this leads to hyperkalemia and not anion metabolic acidosis. So moving on to the treatment of adrenal crisis, initial treatment of hypotension is always going to be your IV fluids. If you know that your patient's hypoglycemic, if you get that finger stick or you have some other way of finding that out quickly, you can add dextrose-containing fluids if the patient needs it. An important point in the treatment pathway is that steroids should be given following attempts at volume resuscitation prior to initiation of vasopressors if you're suspecting adrenal crisis. So preferred treatment in adrenal crisis is a 100 milligram bolus of hydrocortisone. This medication has the added benefit that it has both glucocorticoid and mineralocorticoid effects. So it's particularly effective in underlying primary adrenal insufficiencies, which is Addison's disease. You can also treat with a 4 milligram bolus of dexamethasone, which is preferred if you're planning to do a further workup with maybe an ACTH stimulation test. It has the advantage that it's versus other steroids, that it does not affect the results of a cortisol test that you may be doing in the near future. And so kind of an important point with regards to treatment is that there is always a precipitating cause for adrenal crisis. And if you're not treating that cause, you're not really done. And so once a patient's sort of more stable, continuing to investigate that underlying cause is very important. And depending on the etiology of adrenal crisis and adrenal insufficiency, this patient might need lifelong supplementation with glucocorticoids and other kind of components that are present in the adrenal cortex. So your disposition of this patient will likely be a higher level of care with at least consideration of step down or ICU. All right, so just a few takeaways. It's important to, when you have a patient that comes in with altered mental status, hypoglycemia with an unknown cause, your differential is very wide. But it's important as you continue to sort of resuscitate that patient that you keep adrenal insufficiency on your differential, especially if things are not responding in a way that you would expect. Second, there should always be a precipitating cause, as we discussed, for adrenal crisis, whether it's due primarily to an insult to a component of that HPA axis or a stressor that has exacerbated a primary or secondary adrenal insufficiency. And lastly, steroids should come into play after attempts at volume resuscitation if adrenal crisis is suspected, or especially in cases of refractory hypotension, where you can kind of get to the point of you can look with ultrasound and say, is this patient fluid responsive, or have we given enough fluid? Maybe there's something that we're missing. So it's something to sort of think about. And then here are my references, and these are some adrenals in crisis.
Very nice. As Dr. Sinnert would say, if he was in the room, in the house of God, nobody should die without a trial of steroids. So, believe it or not, you could miss this, and it's very very treatable. So good job, very nice.
It's hard to diagnose. I think that every person who's hypotensive, once we give them 3 liters or even 4 liters, and they still don't come up, I'll give them all 100 of cortisol.
I think I would always do the hydrocortisone if you're thinking adrenal
Don't worry about the spin test.
Sure.
They're not really that important. You should be able to make that diagnosis without it. So
Sure.
just give the hydrocortisone. Sometimes a little bit of mineralocorticoid activity is important, especially if the patient's hyponatremic, right?
Sure.
It also works way quicker than the ones that have to be converted.
That makes sense. Yeah.
It's still real hormone, not the problem.
Very nice job.